Good afternoon. Thank you, Dr. Krieger, for giving an excellent talk on the medical management of Parkinson's disease. Today, I'm going to talk on the advanced management of Parkinson's disease, which mainly includes surgical treatment. This talk comes on the basis of the experience that we have gathered over the last several years. From 1998 to 2019, we have cumulatively performed more than 600 surgeries for movement disorders, out of which 500 surgeries have been deep brain stimulation, and most of which have been for Parkinson's disease. What I plan to do in this particular talk would be to explain you what is exactly deep brain stimulation surgery. We will talk about several components that makes a surgery successful, including which patients to select and how to select, what are the risks and outcome of surgery, challenges and way forward for the surgical development of surgical discipline, and finally, the question that is in the minds of all the people as to what is the ideal setup for a surgical program and how do we evaluate whether the surgical program is capable enough to undertake surgery or not. We have been performing deep brain stimulation surgery for, as I told you, for movement disorders, but not only that, several other indications which include persistent vegetative state, obsessive compulsive disorders, psychiatric disease, depression, cerebellar tremors, and many other things. So exactly what is deep brain stimulation? We have heard this name. This is a cartoon which explains you the deep brain stimulation very nicely. These are the two holes are drilled on the top of the head. Electrodes are passed to the subthalamic or the target nucleus of the brain, which is connected with a subcutaneous wire which delivers current to the target cells through the help of a pacemaker. The pacemaker is implanted at the level of the chest wall. One of the important aspects about deep brain stimulation surgery is that the surgery is performed in awake condition. And why is this performed in awake condition? Many patients ask me this question. To answer that question, I would like to demonstrate this video. Here we are trying to assess the patient's condition at the baseline. You can see that there is a severe rigidity in the hand. The movement of hands are restricted. Very stiff hand. When I ask him to do the movement, you can see that there is a very slow movement. So now 30% improvement, rigidity and bradykinesia in the transition -3, 60% improvement in rigidity. To that end, there is a progressive improvement. Bradykinesia 70%. And when we hit the target, -1, there is 100% loss of rigidity. Complete loss of rigidity. Turn your head fully, nicely, fast. And you can see the movements have improved dramatically. 100% improvement in bradykinesia. Once we have done that, we also try to insert the electrodes in the brain at the same spot, and that is with the help of this image intensifier, which helps us to locate the electrode position in the same place where we had stimulated. The next question comes to all of us is, when should the surgery be offered? Because many patients come to me within 2 or 3 years of disease, and I tell them that this is too early and they need to consider surgery. Some patients come very late in the disease. Either of the things are wrong. So usually we do not offer surgery for a disease duration of less than 5 years. So minimum duration has to be 5 years because most of the time Parkinson's disease is very well managed with medical treatment for the initial few years, and patient doesn't require any surgical assistance. As the disease progresses, as Professor Krieger mentioned, there will be on-off fluctuation. So what is on-off fluctuation? Is that patients would not realize that when the effect of medicine will suddenly wear off. For example, patient has to go out for a function today evening, and usually he takes a medicine at 6 o'clock and gets the effect at 6:30. But on the day when he has to go out or attend a meeting, that day the effect of the medicine will not come. Or let's say, presume that the effect of medicine came, he left for a function, and the effect of medicine is supposed to last from 6:30 to 8:30. He has timed it so that he's 7:30, he will leave from the function and come home. But at 7 o'clock only, suddenly the effect of medicine wears off. So these are called sudden fluctuation or on-off fluctuations. And I'm sure that all these patients who are listening to this webinar would be able to relate that at some point in time they experience that and they are perplexed as to how to handle this. The next side effect of medicine is dyskinesia. Dyskinesia is involuntary movement, dancing movement. It can be slow, minimal, which is minimally noticeable and not hampering, or it can be violent, flinging movement. Like one of the patients explained to me, sir, when I take the medicine and I move around, people think that I'm a drunk person. So that can be as wild as that. Off-face dystonia. When the effect of medicine goes away, the patient complains of dystonia or curling of toes, or sometimes pain in the body, in calf, in back, many parts of the body, and uncontrolled tremor. Any of these symptoms, when you start experiencing, you can consider surgery to help you relieve, because medicine is not going to relieve this. And if you do not want to go into all this detail, the only simple rule of thumb is that when if medical treatment fails to give you an adequate relief, that is the time you want to think about surgery. And adequate relief is different for every different individual. For a surgeon like me, a minimal tremor, which is not controlled with the best medical treatment, would merit me to consider surgical option, as I will show you in a video later. Whereas for a farmer, that tremor is not important. So every person has a different requirement and different threshold, different consideration for deciding about surgery or no surgery. But what I would recommend is that anytime that you feel that you are not getting a good improvement with the medical treatment, or you are not satisfied with the medical treatment, always try to consult a surgical center so that at least you have the perspective of both the world. This is a patient who had been referred to us from US. He was an American soldier, had developed Parkinson disease. You can say there is an asymmetric disease. The right leg is worse than the left. He is not able to lift the leg and tap to the floor. The other one is more freely, and even while he walks, he has to drag the right leg. And this is him after surgery. So when you come early in the disease, the improvement is also miraculous. No one can tell us that this patient has been suffering from Parkinson disease. Virtually normal. Surgery can also be offered in advanced condition, as like in this patient. This elderly lady has got great difficulty and freezing. She is barely able to take one step. See, it took so much time for her to take even one step or stand. She'll be able to stand. Ask her to hold that chair now. She's not even able to stand with the help of chair or support. And the same lady after surgery. You can see her posture has changed. It has knocked off few years of her life from the face. She has become looking more younger and much more independent. So surgery can provide miraculous improvement in patients who are still responding to medical treatment. It is very important that the center also analyzes its data, because we can say that the literature tells or another center claims to have this much improvement, but we want to know whether we can follow up to that standards. So in 2004, we analyzed our first 30 patients who had been followed up for 2 years after undergoing deep brain stimulation surgery. And here you can see that their motor score had improved. Motor score is a disability score, had improved by 60%. And we again refollowed these patients at the end of 4 years to see whether the improvement that we had seen at 2 years remained consistent. And here we can see that the improvement remained consistent at the end of 4 years, and it was 54%. What happened to the levodopa dose? We had around 36% reduction in levodopa, and around the same amount of levodopa reduction continued even at the end of 4 years. And this is very important. And we not only shared this data, but we also published it. And it is important to, because when you try to publish something, then you are analyzed and reviewed by your peers who are equally intelligent and can understand whether you are telling truth or you are just making up the data. It is very important to have centers publishing their work, because that provides an academic level of authenticity to the claims that they make. So what is the outcome of surgery? There is usually 40% to 50% reduction in medication. Some patients can go off medications also, like that American soldier who has got milder disease. There is complete relief of side effects of medicines like hallucinations and dyskinesia. The pain associated with off period is abolished because your on period is extended to 70 to 80% of the day. And there is a weight gain, better sleep after surgery. Patients always report this, and depression improves in 80% of the patients. The next question comes to our mind is that how risky is the surgery? There are several complications that can be associated with surgery, but the only complication that one should be concerned about are the complications of hemorrhage. So what we did was that after first 150 cases, we analyzed our complication rate to understand whether we have been doing the surgery equivalent to the international centers. And we wanted to compare our data with big centers because then only we can understand whether we are comparable or not. So here you can see there are several centers across the world that we have listed from different parts of the world, from Spain, in Canada, Germany, and US. And the complications which are called vascular events or hemorrhagic complications, we had the lowest of all, 1.2%, which is a very, very acceptable level of complication rate for this. Again, as I said, it has to be published. So we had published this in one of the most prestigious journal called Stereotactic and Functional Neurosurgery in 2011. Okay. Now let us understand some peculiar special conditions, because this is something that people want to understand and see whether that is going to help them or not. DBS in the elderly. That is one thing which people have been asking, whether how old the patient can be or what is the age limit for the patient to be operated. We say that there is no age limit. And again, as I said, I back this up from our own experience. The oldest patient that we have operated is 85-year-old. Now, after first 420 odd patients, we analyzed the data of our elderly patients. And this is what we found, that more than 33% of our patients were above the age of 65. And these are the two different targets in the brain that we had offered surgery for: subthalamic nucleus in 143 patients and globus pallidus in 11 patients. Let us take one particular example. This is a 73-year-old man. Probably very few centers in the world would have the capability of treating such kind of patient. Very cachectic, frail, but this gentleman had a very strong willpower. You can see the hand movements are very slow. And he said that he doesn't want to live a life like this and he wants to get better if there is any option. And that encouraged us to take up the challenge. And this is him 2 years down the line after surgery. See, the free flowing movement of the hand is almost become normal. He could speak clearly. His posture has improved. The most important or the beneficial thing about this kind of work is that this improves the quality of a life of the patient and it brings dignity back to the patient, and that is very important. Once again, we wanted to know what is the outcome of this in our patients, and we published our data in Journal of Clinical Neurosciences. We found that the deep brain stimulation surgical outcome was the same in elderly patient as well as young patient. So there was no age outcome difference between elderly or the young patient. There has been a very interesting study which has been concluded a few years back in Europe, and based on this, the USA FDA has given an approval to perform deep brain stimulation in early motor fluctuation patients. Now, this has revolutionized the concept. Previously, we used to offer deep brain stimulation only as a last resort or maybe towards the end of the disease, like after 8 or 10 years of disease. But by that time, what used to happen was that the patient used to leave job or would have difficulty in performing in the job, and he would start scaling down the risk, the amount of work that he would like to do. And here now, basically what they have done is that they evaluated a group of 251 patients who had 4 or 5 years of disease duration, but they had started showing early motor fluctuations. And this study was conducted around 16 centers across Europe, 9 in Germany and 7 in France. Another interesting part that they did was that they evaluated the quality of life as an endpoint. Previously, you saw my earlier slides, the trend was to evaluate motor score and the levodopa dose, etc. But at the end of the day, what the patient seeks is an improved quality of life. And if that is not being provided, other things are not so much of material importance. So this time they decided to evaluate the quality of life improvement after surgery. And what did they found? So 251 patients were divided between surgery and medical team equally. They were offered surgery and medical treatment was offered to the patients under medical arm for continuous 2 years. So after 2 years, they again evaluated. So what did they find? That the quality of life had improved by 24% in the patients who underwent surgery, whereas there was a minor worsening in the best medical treated group. So the surgery outweighed the benefits of treatment. Same thing, UPDRS 3 scores, the motor scores that we talked about earlier, improved by 53% in the surgical group, whereas only marginal improvement was there in the medical group. The levodopa reduction was very striking. There was 40% reduction in levodopa dose, total levodopa dose taken in the patients who had undergone surgery at the end of 2 years, whereas the patient who had taken medical treatment, the doses continued to increase. And I'm sure you would be able to understand why. You yourself must have seen that as the years progress, the amount of dose of medicine that you have to take continues to increase. So at the end of 2 years, there was a gap of more than 50% difference between what could have been achieved. So they concluded that neurostimulation in combination with medical therapy, can therefore improve motor symptoms better than medical therapy alone, even in the earlier stage of disease. We had been following this trend for select group of patients even before this study was done. For example, these patients were operated in 2000, 2004 around that. This study was published in 2013. So this was a 53-year-old gynecologist, Parkinson's disease for 6 years, and you can see that why we operated. He had this tremor and he was losing confidence to continue his practice because obviously when the patients saw tremors in his hand, he was losing the patients because patients would not get operated by a surgeon who has got tremor. This is him after surgery. He could perform independent surgery on his own. The video quality is poor because this was done in 2004 and he had sent it from his surgical theater. He is completing hysterectomy, a gynec operation. Okay, so we saw what is deep brain stimulation, then we evaluated what are the outcome of deep brain stimulation, what are the risks of deep brain stimulation, which are the age groups in which the deep brain stimulation is effective, and what is the effect of deep brain stimulation in different age group. So we have covered majority part of the deep brain stimulation surgery. But let me tell you, that is not the end, that is the beginning. Actually, doing surgery is the first step towards getting an improved quality of life because the entire outcome of surgery is going to be dependent on the postoperative programming. It is like giving you a Mercedes car and not giving you any information as to how to operate this car. This car has got all the functions to protect you, to make your life comfortable, to make your driving comfortable. But if you give it to your driver, he is going to drive it like a Maruti. He knows the clutch, brake, and accelerators. He is not going to understand the computer aspects of that. So unless you know the full programming capabilities of the implants that you have put, you cannot achieve a good outcome. And that is what we have seen. We get every month 2 or 3 patients operated at many other centers around the world and in India, many centers in India who has got a lesser experience. And these patients do not get the benefit after surgery and they come to us for reprogramming. And many times they think that we will replace their electrodes, we'll reposition. We do imagine the electrodes. Sometimes we find that they are not optimally placed, but we do not like to replace or reposition all the electrodes. Very rarely we reposition the electrodes. Most of the time, with the help of the programming skills that we have, which can be used to titrate and program each individual contact point with millions of combination, we get the benefit. So It requires a long-term experience. We have built up our experience of hundreds and thousands of hours over last 20 years because we have programmed each and every patient ourselves. Our team has been learning along the way. Our patients have made us become better and better. We do not entertain any medical representatives to program, or the program is completely done by our medical team. Patient has a finite number of time and patience, so we have to achieve the results within that period. Let us talk about some technical advances. The new techniques that we are likely to get are the directional lead. In fact, we have already got this in our country, and some centers we have used it also. And these are segmented lead. Basically, what it does is that in the standard configuration of the electrode, there is a cylindrical contact. So when you stimulate this contact in the center, it will drive the current equally circumferentially. Now, suppose your target is the green target and the side effect area is the red. Now, when you want to stimulate this, you will have to increase the strength of the current to cover the green target. But unfortunately, it will also spread to the red, minimizing the benefit that you can get. Now, let us understand this segmented lead is used. So what it does was it will use this segment and this segment A and segment B of the, let me show you a little better. So segment A and segment B are stimulated and segment C is not stimulated. So this area will not get any current. You can see that this is not getting current, whereas the segment A and segment B will push the current to cover this green structure. There have been advancement in the pacemaker technology as well. Now we have got much more complex programming capabilities in each pacemaker, individual pacemaker. The pacemakers have become MRI compatible also. They have become smaller in size. The charging time has decreased. The longevity has increased. We have now pacemakers which can last for 25 years. So that is all changing. Over a period of time, we are likely to get in a few years' time, 2-3 years' time, something like this, a USB kind of pacemaker, which can be implanted on the head only. So no problem of infraclavicular implantation. You can just implant it on the top of the head. And you can see that even as compared to the smallest of the smallest pacemaker in the world, it is 1/4 of the size. As I told you, the capability of programming is endless and it is still further improving. So novel stimulation paradigms are being used. One of them is called local field potential. What it does is that senses the electrical current from the brain or electrical activity from the brain and gives the current based on that. Now let me explain you in this particular slide. Here, this is a patient who has undergone left and right subthalamic nuclear stimulation. This is the time when his local field potential, although activity in the brain is very high, so he has to receive a very high level of current to control the activity in the brain and to reduce it. Moment he takes a levodopa or medicine, you know that the medicine effect will come and the activity of the brain cells will reduce. The firing in the brain will reduce so that Parkinson's symptoms improves. Now, what happens just now conventionally that the current remains the same because we do not fluctuate the current over hours and minutes. But here, because it is able to sense that the electrical activity in the brain has reduced, it drops down the current. And you can see that the current, which was around 70-80% requirement, was dropped down to 25 to 30. And this gives not only effective treatment, minimizes the side effect, but also prolongs the battery life. Another programming capabilities is a therapeutic window improval by decreasing the pulse width. Again, new pacemakers are offering this advantage. So some patients have a low threshold between improvement and side effect. So we get improvement at 3 volt and side effect at 3.2 volt. So how do I improve this? Therapeutic, this 3 to 3.2 is called therapeutic window. Amount of voltage between getting an improvement and side effect determines how much you can benefit the patient. So by reducing the pulse width, now I can get the improvement at 3.5 volt, but the side effect will only come at 5 volts. So now my therapeutic window from 0.2 has increased to 1.5. And that is the technique which has helped. Many patients with advanced Parkinson disease 4-5 years after DBS starts developing freezing of gait. And that is a part and parcel of advancing Parkinson disease. Now, low frequency stimulation used in some of these patients can benefit and improve their freezing of gait. We are learning as we go along, as I told you earlier. Now we are talking not about the target cell or the target group of cells. We are talking about volume of target or the total volume activated after by the current. And you can see this in this particular slide, what I mean. Previously, we used to use a conventional current to stimulate, which would convert part of the nucleus stimulated and the other part of the nucleus, the current will spread to the neighboring structure, causing side effect. But when we now have atlases and computational model to help us direct our therapy only to the targeted group of cells, which reduces the current and which also improves the outcome. Finally, to end the talk, after all this, what the last question that comes to your mind is, so if we have to get operated, where do we go? The question is that you need to have certain criteria for that. By my talk, you would have understood that surgery, doing a surgical procedure is one of the smallest part of the entire exercise. It's a comprehensive treatment that can be offered or that is required for this Parkinson's patient that makes the surgery successful. Because if one part of the surgical uh, team or function is not adequate, the outcome will be suboptimal. So I would go for a surgical center which has got at least 10 years of experience. European Society of Functional Neurosurgery recommends that if your surgical center has to be called a training center, that means you have already established and learned the skills of surgery, you should have at least performed 200 deep brain stimulation surgery. It should have a team. At Jaslok Hospital, we have not only the team, but we have a very huge group of dedicated people focused in the management of DBS patients for last 15 years. Our urologist has been there. Urologist makes an important part of the team. The neurologist, we all know that it goes without saying. We have a psychiatrist who has been there for last 20 years. He has been treating each and every patient that we have psychiatric problem with. Psychologist, we have gastroenterologist, and you would understand that some or the other part of the time of your disease, you might have had required or you will require the help of these people. And if these people can understand what DBS can do, what Parkinson medication can do, and what their medication is required to do, then only you will get the benefit. If you go to a gastroenterologist standalone with a constipation request, he will treat you totally differently. But the person in our team will understand that DBS can help you particular part of the constipation. Medicines will, this medicine is causing constipation, so remove that and use the current to do that. And if that is not working, then bring the medications from the gastroenterologist. Same for urologist. He will not offer you surgery for every prostate that he comes across. See, all these things are very vital for getting a functional outcome which is unique. The final additional criteria should be how long has the surgical and medical team been gathered? Because this is a learning curve. If your driver and the navigator keeps on changing, you cannot win a car race. Even the car race, the team has remained constant because then they understand each other's body language. What is the experience in case of programming? Because after surgery, you require excellent programming capabilities. What the patients have to say, because obviously even today you go to Amazon to buy a small mobile phone, you will check out for reviews. So when you have to put your life at stake, I'm sure you would check for many reviews. Accessibility for trivial problems. Patients become very dependent once they undergo surgery. They become very demanding, not dependent, but demanding. Once they undergo surgery, they expect that if there is any problem, they get very apprehensive and they want an answer. We have a setup where you can access us 24/7. And the last is the strength of the center is by how it is perceived in the eyes of another group of similar centers in the India and across the world. Is there a fellowship program? Are there academic publications? Are the centers representatives on the board of several societies? Because this all adds value and brings knowledge back into the center, which can be utilized for the patient. I think with this, I would like to end and thank you for a very patient hearing. And I would like to take your questions now.